You know, a liver transplant has to be one of modern medicine's greatest triumphs. But the moment the surgeon makes that final stitch, that's not the end of the story. In a lot of ways, it's just the beginning. The real battle for a new life, well, that's won or lost in the hours and days that follow inside the intensive care unit. So let's step inside the ICU and see how that battle is truly fought.
Okay, look at this number, 66%. That was the 10-year survival rate for folks who got a liver transplant back in 2010. That number represents a huge leap forward for what was once a pretty experimental procedure. But to really get how incredible that is, you need a little bit of context.
And this is what really puts it into perspective. In just over a decade, from 1998 to 2010, the 10-year survival rate literally doubled. Now, this wasn't just because surgeons got better with a scalpel. This revolution happened because of massive improvements in how patients are cared for after they leave the operating room, especially in the ICU.
So how does the team actually navigate this incredibly intense journey? Well, we're going to follow the patient from the OR right into the ICU. We'll explore the body's delicate balancing act, see how doctors know if the new liver is even working, and finally, we'll look at the complications that can pop up along the way.
All right, so that journey from the operating room to the ICU, it's one of the most critical handovers in all of medicine. The team waiting in the ICU has to immediately understand a whole unique mix of factors that define that patient's condition, right? At that very second.
And the thing is, no two patients show up in the same condition. It's never that simple. The ICU team has to process all of this on the fly. How sick were they before they even got to the OR? How good was the donor liver? How long was that organ without blood supply? That's the ischemia time. And what exactly went down during the hours-long operation? All these variables create a completely unique puzzle for every single patient.
Okay, so the patient is in the ICU. Now what? The first huge challenge for the team is to take a system that's in total chaos and somehow find balance. They're trying to manage the body's massive and often contradictory responses to a major surgery and, a brand new organ.
Right off the bat, here's the #1 goal. Keep the mean arterial pressure, or MAP, above 70. You can think of MAP as the average pressure in the arteries. Keeping it above that magic number is absolutely crucial. It ensures there's enough oomph to push oxygen-rich blood through that brand new liver and, just as importantly, through the kidneys, which are under incredible stress.
But hitting that stable pressure, it's tricky. And that's because of a pre-existing condition called hyperdynamic circulation. Basically, before the transplant, their heart was pumping like crazy, but their blood vessels were wide open, so overall pressure was low. It's kind of like a car engine that's stuck revving in neutral. It takes months for the body to learn how to idle properly again, and the ICU team has to manage that imbalance from minute one.
And this quote, man, it just perfectly captures the next massive balancing act. The new liver isn't quite up to speed making all the clotting factors it needs to, so the patient is at a high risk of bleeding. But at the same time, the stress of the surgery can create dangerous blood clots, so the team is literally walking this tightrope, trying to prevent both catastrophes at once.
And if a patient does start bleeding, there's a very clear protocol. First, you got to fix the coagulopathy, the body's inability to clot, using blood products. Second, you stabilize their blood pressure. Third, you might use special drugs to protect any clots that do manage to form. And if all of that fails, the only option left is to go back to surgery.
All right, so let's say the patient is relatively stable. Now the focus shifts to the one question that's on everyone's mind. Is this new liver actually doing its job?
I mean, how do you really know? It's not like the liver has a little green light that just flicks on when it's working. Nope. The team has to rely on a whole collection of clinical signs and lab results that, when you put them all together, paint a picture of either success or failure.
In this table here, it just lays out the stark difference. On the left, you have all the signs of success. Blood pressure is stabilizing, the liver starts making bile, the patient's mind starts to clear up. But on the right, you have the warning signs of failure. They need more and more blood pressure support. They can't form clots. And, maybe the most ominous sign of all, their blood sugar starts to crash because the new liver just can't keep up.
And that brings us to the absolute worst case scenario. Primary graft nonfunction, or PNF. This is a complete, irreversible failure of the new organ. It's a total catastrophe. The only solution is an emergency retransplant, which puts everyone, the patient, the medical system, right back at square one under the most intense pressure you can imagine.
Okay, so let's say the graft is working. The next big threat? It actually comes from the patient's own body. The immune system is designed to attack anything foreign, and it sees that new liver as a major invader. So, patients are put on powerful immunosuppressant drugs, like tacrolimus. These drugs are absolute lifesavers, but they come with a hefty price tag. The side effects are serious. We're talking kidney damage, neurological issues, high blood pressure, even diabetes.
And this brings us to our last major hurdle, navigating the cascade of other complications that can pop up. The immense stress of the surgery, combined with those powerful drugs, creates a ripple effect that can touch every single organ system in the body.
So on top of everything the body is going through system-wide, you've also got to worry about the plumbing, the actual surgical connections. As you can see here, these can range from immediate bleeding where things were sewn together, to blockages or leaks developing in the bile ducts days or even weeks later.
You know, the kidneys, they take a real beating in all this. And as you can see here, the risk of some kind of renal dysfunction after the transplant is huge. It could be anywhere from 5 to 50% of patients. It's that ripple effect in action, caused by this perfect storm of pre-existing problems, unstable blood pressure, and those kidney-toxic drugs we just talked about.
And the brain isn't safe from all this stress either. I mean, look at this. Up to 42% of adult recipients experience some kind of neurological issue. It could be confusion that was there before the surgery, or it could be a toxic effect from the immunosuppressants. We're talking about a huge range of problems, from tremors all the way to seizures.
So you hear all of this, all these complex, interconnected problems, and you have to wonder, how is success even possible? Well, the answer isn't some magic bullet. It's a symphony of highly coordinated care.
Because success in the ICU is never a solo act. It's a full-blown symphony of specialists. You've got the intensivists, who are basically the conductors of the orchestra. Surgeons consult on the plumbing. Specialist nurses are like the first violins, constantly watching the patient. Pharmacists make sure the complex drug regimen is perfectly in tune, and physical therapists help rebuild strength. Every single person is a vital instrument.
And that really leaves us with one final thought. A surgeon can give a patient a new organ, that's for sure. But turning that marvel of modern surgery into a lasting, healthy new life? No. That takes this incredible, minute-by-minute symphony of expertise, of vigilance, and pure human collaboration in those critical first days and hours, turning a procedure into a true new beginning.